everyone. I'm Megan McGurman.
And I'm Jason Tokarski. Welcome to the first episode of Season 2 of For the Love of Health, brought to you by ChristianaCare.
High quality and safe care are two things you'd expect from any healthcare experience. ChristianaCare has achieved national recognitions, awards, and accreditations for quality and safety. But what does it all mean?
For our seventh topic in our toughest questions in healthcare series, we're asking, why are quality and safety so important in healthcare? Here to tackle that question are Dr. Kert Anzilotti, ChristianaCare's System Chief Medical Officer and Interim President of the Medical Group, and Tim Bowers, Vice President of Clinical Effectiveness at ChristianaCare. Tim and Kert, thank you so much for being here today.
Thanks for having us.
Thanks for having us.
Recently, U.S. News and World Report ranked Maryland number 1 and Delaware number 2 in the nation for hospital quality. When the community sees rankings like that, they see the billboards, they see the logos. What should the takeaway be there?
Like in many industries, there are a number of external entities that rank the performance of the people providing care, if we're talking about healthcare. Most people recognize U.S. News because of the other industries that they rank, like colleges is one that people know a lot about. Each of these reports that you might read about in the news are all based on standard data that hospital systems submit to CMS as part of the national quality and safety initiatives. With a performance report from U.S. News, which most people see as a recognized entity, you can feel very confident that the thing that's being ranked, healthcare quality, hospital quality, Delaware and ChristianaCare is one of the highest performing in the nation.
And what metrics are tracked and submitted in order to be able to compare hospitals against each other?
In looking at some of the more rigorous measures that are out there, specifically the CMS star rating, which most of these organizations base their ratings off of, the metrics really are taken from our claims data. So when you go for healthcare, your insurance or the organization defines it by specific codes, and those codes mean something on the back end, some of which are hospital-acquired infections, hospital-acquired conditions. Some of them are related to the way that we treat the chronic diseases that you come in with. And so all of these get put into the kind of this big database, and then CMS is able to look to see who is doing well and who is not doing well. Some of these measures, as I said, hospital-acquired conditions, hospital-acquired infections, CLABSI, CAUTI, are measured the same way across every hospital in the entire country. Same thing as it relates to the readmissions or other patients that come in with chronic conditions.
You mentioned a number of acronyms there that the average Joe or Jane probably doesn't necessarily make a whole lot of sense to. CAUTI, CLABSI, CMS. What are these terms? How do they factor into the rankings that we're talking about here?
Sure. CMS, to start out with, is Medicare. It's Center for Medicare and Medicaid Services. And so that is an acronym that is used very widely and very often. So apologies for starting with that acronym. The other are more specific to patients that are in the hospital. So a CAUTI or a CLABSI is a catheter-associated urinary tract infection or a central line-associated bloodstream infection. And so either of those, whether it is a catheter that you need for urinary retention or another malady that you're here for that we're treating, puts you at increased risk for an infection or for a condition that could actually make you worse. And that's obviously not something that we want to do. That's not something that any organization wants to do. And most organizations treat them like never events. And so we use the acronym so that we're not saying catheter-associated UTI, central line-associated bloodstream infection, over and over and over again. Some of the other measures include the EDAC, which is excess days of acute care. So if we do our job correctly, our caregivers are providing the best care they can. They are identifying the issue. They are treating it appropriately. They're handing it off to the appropriate post-acute partner or just discharging you home. And then you never have to come back to the ER, to the hospital again. And so EDAC measures that. And so those are some of the ways that we measure quality within healthcare and some of the acronyms that we use.
Preventable harm is certainly a priority for health systems across the country. What is ChristianaCare doing to prevent harm?
Preventable harm is a major area of focus for all of the ChristianaCare facilities. We like to think of ourselves as a high reliability organization. We use data. So some of the data that Tim was just talking about, we track that on a monthly basis, and we identify areas where we may have opportunity or where we're performing well. We put a lot of effort into making sure that our caregivers, doctors, nurses, support staff are experts in things like central line maintenance so that somebody doesn't get an infection of their central line. We educate them on best practices. We watch them. Leadership watches them to make sure they're using those best practices at the bedside. And if we need to re-educate, we're constantly doing those cycles. And as I said, we monitor the data. It gets refreshed every month, and we can tell when there may be an opportunity in a particular patient or a particular area of the hospital. And with that constant cycling, we're able to have the performance that we have, which is one of the best performances in the country.
Another term, I suppose I keep asking these questions, that has been brought up is zero harm. What does that mean in terms of what we're talking about, and what is ChristianaCare's goal in where that is concerned?
So zero harm is an idea that came into healthcare over a decade ago. It's philosophically, it's the idea that one day, 1 month, 1 year, we will have no preventable harm events in our organization. And it's an aspiration that we drive to every single day when we're providing care. The journey to zero, or that aspiration, in reality never ends. So even where we do see zero, we have many units that have gone a month, a year, 3 years without a particular harm event. We know the work just starts again the next day, because achieving zero doesn't mean you don't have to worry about it anymore. We have to continuously drive to preventing harm in the organization.
And what is it about the units that are hitting zero harm that makes them stand out? What are they doing to hit that goal?
Some of it has to do with their patient population. So there are some units that have sicker, more complicated patients, and therefore it's harder for them to achieve zero. But a lot of it is what I just previously talked about, having a workforce that is highly trained on best practices, applying science and standard protocols to things like maintaining central lines, to people are usually familiar with urinary tract catheters, Foley catheters, making sure that we're only using those when we need to, we're not leaving them in too long, we're maintaining them accurately. It really is an endless journey towards excellence to try to prevent some of these things.
Kert, you mentioned education and making sure that all of the caregivers in this health system fully understand how we strive to this preventable harm goal and everything else that falls under the quality and safety umbrella. How important is that day to day in both of your roles, making sure that these caregivers are confident in keeping patients safe and healthy?
On a daily basis, that's the most important part of the job. We can talk about what the best practice is, or we can implement a protocol, but unless it's being actively delivered at the bedside, it's not going to be impactful. So Tim and I regularly round at all of our hospitals and meet with nurse managers, chief medical officers, and it really is an ongoing process of observing care being delivered, learning from the literature, because these things do evolve and change over time, educating people and observing their care so that we can prove to ourselves, as not as individuals but as an organization, that we truly are delivering that care that is the best care as we've defined it.
Sounds like we've been making a lot of progress here at ChristianaCare towards that goal, and understood, as you've said, that it's an ongoing thing. It's not you get there and you're done. What other wins does ChristianaCare have beyond that zero harm goal that you're shooting for?
So some of the other goals include our work in health equity, and it is very important for us to make sure that we have zero harm, not just in most of our patients, but in all of our patients. And a lot of that has to do with understanding the differences that our patients bring in with them. And so how do we adapt our care to make sure that everyone is able to be free from harm? So that work for us has been ongoing for years. Otherwise, there's this some of the measures I talked about before as it relates to our chronic conditions were around, it's called survivability or mortality. And so if you come to us with a chronic condition or a heart attack, pneumonia or COPD or heart failure, there's a good chance if you're sick enough to be in the hospital that not all patients will survive. And so our work specifically relating to improving mortality has launched us into the top 10 of academic hospitals in the country as it relates to that performance. And it really has been phenomenal work, both in the way that we document within the medical record, but also making sure that we're providing the right care in the right way to the right patients. And so those two really, for me, are huge wins. And I really appreciate all the work that all the caregivers and leaders have put in to make sure that we're being successful there.
Let's expand beyond that. What is the national environment, the national scope as far as patient safety and quality is concerned when it comes to care?
This is a conversation that's going on throughout the nation in healthcare. All healthcare facilities are engaged in this and are aware of their performance.
There are no secrets in quality and safety. If we find something that works, we want everybody to use it. So we shout it from the hilltops, and we listen to others that are finding other ways to do things just as well, if not better. And so it's kind of like the journey to zero harm, where there's always something else. There's something else that we can do. There's a way that we can make this environment safer for everyone.
As part of our toughest questions in healthcare series here on the podcast, we've regularly asked the question of what the future looks like. So give us a little bit about what you think you can see the future of patient safety and quality and zero harm could possibly be.
One area on the national stage that's just coming into the conversation is expanding the quality and safety agenda into the outpatient arena. So a lot of the metrics that we're talking about and a lot of the things that CMS tracks and U.S. News and World Report is using to generate their rankings is based on inpatient hospital care. So the things that may or may not be happening when you're in a hospital bed in a hospital. The next wave of this is ambulatory. So going to your doctor's office, going to an imaging center, going to a rehab or a physical therapy facility that's not inside the hospital. We'd like to think that we're on the leading edge of that. We do have a strategy for ambulatory safety in our organization, and we do set goals every year. I think one of the biggest areas where we're looking to the future is trying to think about other areas where we can provide care. So we have a very large initiative going on right now where for certain diagnoses and certain patients, we can actually provide hospital-level inpatient care in their home. And when you do that, you can eliminate some of these risks that we've talked about. You can create an environment that maybe has less of a fall risk, patients more familiar with. You can eliminate some of the risks that maybe come with some of the infections that we've talked about. Just thinking about how can we be pushing the envelope on right care, right place, right time, and providing some of this care in a place that's safer for people. Another place we're looking to the future, and I know it's being applied all across our society, is using AI to help us with quality and safety. So how can we use big data sets? How can we use AI to not identify the next infection, but identify the situation where the next infection might occur before it actually occurs? So a lot of research going on in that. We are learning, but the more we can be proactive and preventing these things before they actually happen, or even the risk of them happen comes into the care space, the more successful we'll be.
Clearly, patients expect high quality, a safe experience when they're at any hospital. But are there things that patients and families can do on their own to be proactive about that as well and to help your teams make sure it's the highest quality experience possible?
First thing you can do is communicate, and communicate whether it's with the loved one, if it's your family member that's coming in for an inpatient or outpatient visit or procedure, with the care team to make sure that the expectations that you have of what's going to happen before, during, and after are actually what the provider or the clinician believes as well. If something doesn't seem right, something feels a little off about you or your loved one, have that conversation early, so that way if there is an issue, it can get caught. It may be something that the clinician expected was going to happen, and they can have that conversation with you at that time. But I don't think you can over communicate as it relates to your expectations, and then afterwards, if you feel like there's something else that needs to happen.
If you're having a surgical procedure, there may be some pre-surgical things that you're asked to do, whether it be use a special wipe where you're going to have the surgery, or take some medication in preparation for that surgery. And then similarly, when you go home, there's usually a number of steps that people are being asked to do as their body starts to heal. Families can be very, very engaged in that with their loved ones. Inpatient hospital care is a team sport. Wash your hands while you're in the hospital. That's probably the best thing all of us can do. But be aware of your loved one. Maybe they have some unique risk factors. Maybe they have some unique medications that they're on. The more we're all together aware of some of those things, like an elderly relative who maybe has a fall risk that you're aware of and you want to let the team know about, the more we are aware of these things, the more we can be addressing them proactively and preventing them.
Tim and Kert, thank you so much for talking to us today.
Thank you.
It's a pleasure.
For a deeper look into quality and safety at ChristianaCare, check out ChristianaCare's 2024 Quality and Safety Report. The link can be found in the show notes for today's episode.
And don't forget to subscribe to For the Love of Health on Apple Podcasts or Spotify, and watch the video version of For the Love of Health on ChristianaCare's YouTube channel.
We'll be back in 2 weeks with another great conversation.
Until then, thanks again for joining us.
For the love of health.